obesity and diabetes late in life. It's not only the best gift to a child, but it also provides support for a mother. It supports emotional bondings between mother and the babies, along with other mental health benefits. It also reduces the mother's risk of breast and ovarian cancer, especially type 2 diabetes and high blood pressure. So in West and Central Africa, sad to say, there's only 46 of babies, meaning only 1 in 2 babies are put to the breast of their mothers within the first hour of life. So we have around 20 million babies born in the region in 2021. And this means almost 11 million babies actually in this region are missing the chance to receive the first and the best gift from their mother. So despite all the potential benefits, only 37%, so less than 2/5 of infants less than 6 months, are exclusively breastfed. Even when mothers give birth with skilled health personnel in health facilities, not all the mothers and baby benefit from this early initiation of breastfeeding. So we must give the mothers and the baby the support they need for breastfeeding, for the best start of life. So in 2018, WHO and the UNICEF updated both guidelines and guidance on baby-friendly hospital initiatives. This new guidance recommend that countries integrate baby-friendly hospital initiative approach into health system to support the breastfeeding. Now more than ever, we need to think how to promote breastfeeding in a system. However, many countries in this region actually struggle with implementing this approach. So the main challenges include the lack of an updated set of global tools to monitor, to assess, or implement the approach in the poor integration of baby-friendly hospital initiative into national policy and standard and designation of health facilities. So another challenge is insufficient support to the health facilities to close gap between the knowledge and practice. The key cares for mothers and baby, such as immediate and uninterrupted skin-to-skin contact, practical breastfeeding support for mother and referral to the appropriate community services should be provided with quality. So we will not let you alone in this. So today, in this webinar, we are going to share the current global guidance on the 10 steps to how successfully we go for breastfeeding. So we'll hear from our colleague from East South Asia of the Center of Excellence for Breastfeeding Approach. We also have a panel discussion with countries of our region, and we'll have time for question and answers. So please stay tuned and let's begin this exciting journey together. Thank you very much.
Thank you. Thank you so much, Susie. It's lovely to hear those, the keynote speech from you. It's a bit shocking to hear that 11 million babies in our region do not benefit from breast milk, and that is quite a shocking statistic. And I know that we all collectively can make a change in that statistic over the next few years. Let's move on, though, to hear some opening remarks from Sean Farrell, who represents the government of Ireland. Sean is currently the Deputy Head of Mission for the Embassy of Ireland in Hanoi, covering Vietnam, Laos, PDR, and Cambodia. Before joining the Department of Foreign Affairs, Sean spent 25 years managing development and humanitarian assistance programs in countries across Africa, Asia, and Latin America. Sean, we're very grateful to the funding provided by the government of Ireland and enabling Alive and Thrive in Vietnam to really test and try out the centers of excellence. So thank you for supporting this innovation over the past few years. And let's hear from you your thoughts on this approach. Over to you, Sean.
Thank you, Nemat, and good morning, good afternoon, and good evening, representatives from UNICEF, from the World Health Organization, and from Alive and Thrive. It's a real privilege for me, representing the Embassy of Ireland, to be with you today to really hear some input on excellence for breastfeeding and learning from the experiences in Southeast Asia. I would like particularly to thank our partner Alive and Thrive for inviting me to speak today, and also to thank all of you who are attending from multilateral organizations, from NGOs, and from other development partners. As you may know, Ireland has consistently supported efforts to improve nutrition across the world, and breastfeeding and supporting this has been central to our efforts. 1/5 of babies under 6 in our world today are undernourished. And as Susie said, breastfeeding is one of the best gifts that can be given to these babies in their first 6 months of life. For Ireland, the work that we do on this is rooted in a global commitment to a world free from poverty and hunger. This very much is rooted in our own experience of famine and our own experience of deprivation as a country. And that has inspired the work we do today in development assistance, and also particularly the work we do on combating hunger and supporting nutrition. We know that in Southeast Asia, and particularly in Vietnam, Cambodia, and Laos, the work that we have done with Alive and Thrive across these countries has allowed us to do work on advocacy and also provide technical assistance to consolidate gains made already in breastfeeding. And we look forward to working with many of you, to working with governments, multilateral, local and international NGOs to advance this agenda over the coming number of years. I want to finish by saying that over the past 15 years, we have seen huge and encouraging progress in reducing chronic and acute malnutrition in Southeast Asia. And from that experience, many useful lessons have been learned. And I think this workshop is an absolutely crucial opportunity to share experiences and to contribute to the improvement of nutrition between the regions in Southeast Asia and our colleagues who work on the African continent. I wish you all a fruitful webinar today, and I look forward to hearing all the discussions and practical exchanges from the different country contexts. Thank you very much, everyone, and thank you so much, Nemat.
Thank you, Sean, for those opening remarks. And again, a big thank you to the Government of Ireland for supporting breastfeeding and infant feeding in young children. And really, as you mentioned, the commitment of Ireland to reducing hunger and poverty globally, not just in Southeast Asia. So with that, we're going to move on to our first presentation for the day. We are all familiar with the baby-friendly hospital initiative, and we know that there are the 10 steps to successful breastfeeding. The guidance was updated, as we heard Susie mention in her talk. And now we're going to hear from Hannah Bekele, who is the Senior Nutrition Advisor for WHO Afro, the Intercountry Support Team for Eastern and Southern Africa. Dr. Hannah has over 20 years of nutrition and public health experience with both UN agencies as well as non-governmental organizations. So Hannah, over to you to help us refresh our memories on what the new guidance is all about and how it compares to the old guidance. Thank you. Dr. Hannah, you are muted. If you can unmute yourself.
Okay.
There you go.
Good morning, good afternoon, good evening, colleagues. I will put off my video because of the connectivity problem, if you allow me, and I will proceed. First of all, Thank you very much for providing me with the opportunity to make a very, very brief presentation on the global guidance to the 10 steps to successful breastfeeding. Next slide, please. I will start by describing the overview of the updated BFHI guideline with a focus on what has changed and the key takeaway messages. Next slide. So what is the guideline telling us? The guideline is telling us that the BFHI is a responsibility of every maternity facility. That doesn't necessarily mean hospitals. Whatever the health facility, wherever it is providing maternity care, should implement BFHI. Countries are also advised to have the national standard of care. As you know, there is a global standard of care, but you need to adjust it because you need to monitor. Based on the global countries, before starting implementation, the national standard is very important. Do not only focus on the public hospitals, private hospitals should also do. So to say, private facilities as well. And also, the BFHI must be integrated with other healthcare improvement processes in place, including quality assurance initiatives. It depends what each country has. The guideline also encouraged us to switch from designating our facilities to becoming BFHI, which they can still do it. There is no harm in it, but that should not be the focus. Incentives must be, we need to look for ways of incentivizing those health facilities with doing BFHI to continue doing it, until it becomes a part and parcel of the routine activity and is also normal for that facility. Another important area which is added into this guideline is regular internal monitoring. Very crucial, because this is a skill-based initiative, so we need to monitor, and teaching them one time is never enough. So that's what it is emphasizing on. For external assessments, which facilities or countries are very much interested in designating themselves, it has to be streamlined and should be part of the existing management and resource system. You should not be doing it in parallel. So after saying that, so what has changed? Actually, the most important part is the inclusion of the preterm and low birth weight into the BFHI system. So I think this document is published in 2020. If most of you haven't seen it, you can always check WHO website, including the UNICEF website. It's saying protecting, promoting, supporting breastfeeding, the baby-friendly initiative for small, sick, and preterm newborns. Okay, you've got lots of details. So we divided into the same thing. The 4 management procedures are under the first 2 management component, and the other 8 are the clinical parts. Next slide, please. So for the benefit of all of us to remind ourselves what was the BFHI before 2018, I think I don't want to go through it, but having a policy to communicate to the health workers and then train the health facilities to implement that policy, and informing pregnant women about benefits and management of breastfeeding, and also helping them to initiate breastfeeding as soon as after birth, and then showing mother how to breastfeed and maintaining lactation. Also emphasizing newborn should not be getting any drink or other than breast milk during that period unless medically recommended. Because I'm going to few of these steps that change have happened, I just wanted to go through it so that you keep that in your mind as we go through. Practicing rooming in is also has always been the part. Encouraging breastfeeding on demand, give no, that's probably where the major change is, give no artificial teeth or damage to breastfeeding infant. And of course, the last one is identifying whatever resources available at the community level to refer those breastfeeding mothers to those groups. Next slide, please. So the first part, which we see quite a number of change here, is in the managerial part, which is the critical, we call it the critical management procedure. Just to tell you, like, there are two categories that we should keep in our mind. One is the critical management procedures, which includes step 1 and step 2, which gives us 4 operations, and the rest are called the clinical practices. So the first one, as I mentioned earlier, was written as have a written breastfeeding policy, which really communicate, put it somewhere where people see. But that needs to be converted into practical, I would say, actions. So as it is divided into 3 parts: complying with full international code, and and of course the relevant WHA's resolutions have a written breastfeeding policy. That was what we had previously, and establishing an ongoing monitoring. The rationale is that I think what is very important for us to keep this in mind is the code as it is every health worker, regardless of the situation, should comply to code. So that wasn't emphasized before. That's why we're bringing it here. And also in this prenatal period, the families are so much vulnerable. That's when they come frequently for checkup and also asking for information what they should be feeding their baby, etc. So that is the critical time where industries are targeting. So we need to make sure that this is well attended to. Another important part is the ongoing monitoring system should be put in place to see what is changing. That's why the step 1 has been divided into 2. Training the health care staff to implement the policy, which is general, but in this case, it has been divided by focusing. The emphasis should be on the competence side of it. This is part of the course, and we must not only focus on the training, we need to also do follow-up training to our health workers as well. Next slide, please. So the next one is the 2 of them here, number 5 and number 7 changed. I read you the previous one, thinking that you have some of them in your mind. So the number 5 was saying, show mothers how to breastfeed and maintain lactation, even if they are separated from their infants. So the details in this area this is like, what are we showing them? How do we supporting them? What does that management mean? So if you break it down, first of all, is checking the usuals, the ABCs of support that we give to the mother so that the baby can latch into the breast, positioning, attachment, and the suckling. And then give the additional practical support so that the mother can continue to do that in the health facility. And also it's important that mothers should know how to evaluate the milk intake, because that's something that always worries them. That's why we are saying what are the key criteria that the mother should keep in mind to ensure her that she's doing well. So I think those are the things that we wanted to let mothers know. And supporting mother of preterm and sick infants, this is critical, so that they must learn about the expression of breast milk within 1 to 2 hours after birth. So the breast milk continues to be produced, and also helping mothers with the common breastfeeding problems. They might as well know, they also act on it before things get worse. So these are the things that breaks it into different actionable statements, which helps the trainers and also those health workers in how to support the mother. And the second one, then the step 9, which is the big one, I would say, give no artificial teats or pacifiers to breastfeeding infant. So it is like in the guideline, you wouldn't find that it is no longer prohibited and mothers should be counseled on how to use it. So the question here is why are we doing this, etc. But the evidence that has been collected when examining the relationship between introducing this earlier and after the birth, days after and within the facility, it's an interesting finding. I mean, to summarize, the evidence of pacifiers did not show a benefit to restricting the use and even seem to be beneficial for preterm. I underscore this, preterm infants, and we have not found evidence that use teats or bottle feeding that result in nipple confusion at the moment. So we are very careful in communicating this message, counsel mothers on the use of the risk of feeding bottles and teats and pacifiers. That's what they want to do. The information that should be provided during such a counseling should include evidence-based recommendation from the guideline. For preterm infants who are unable to breastfeed directly, non-nutritive suckling and oral stimulation may be beneficial until breastfeeding is established. If expressed breast milk or other feeds are medically indicated for the term babies, feeding methods such as cups and spoons and feeding bottles and teats may be used during their stay at the facility. If expressed breast milk or other feeds are medically indicated for preterm infant, feeding methods such as cups and spoons are preferable to feeding bottle and teats. So in sum, it is important that this recommendation is understood together with the recommendation to avoid supplementation, which is with the expression of milk or formula, breast milk or formula milk, unless medically indicated. Overuse of either supplement or bottles and teats is harmful. If mothers are counseled and choose to use bottles and teats, they should also be taught to clean and disinfect them before every use. I emphasize this because this is very important. Next slide, please.
So Dr. Hannah, we're going to request you to start winding up. Thank you.
Okay, so the last one is quite easy. I think it's us to know where the mother should be referred to instead of only limiting, telling them to go and find their own group. So health workers need to find and then also ensure that the mothers are linked. Next slide, please. Well, the message, takeaway message, each facility needs coordination committee. I think that is good. The existing ones could also be used for the quality improvement, etc., and utilize that one to make sure that staff participated and also leadership engage in this. Motivational support is very important with regard to concrete skills that we are trying to help mothers to know and breastfeed. We have to be very careful in preterm newborns, and we need to maintain follow-up and so that the mother may maintain breastfeed production. Next slide. Guidance is required for family members to enable them make informed decision on use of pacifiers and feeding bottles and teats. That's critical. And the cups and spoons and feeding bottles are used for medically indicated reasons. This one is clear. But we should not promote bottle feeding or teats in any part of the facility or by staff. Next slide, please. So mothers value for us to know the linkage of breastfeeding support after discharge, and the discharge facilities need to be linked with each mother wherever that is possible. So there are various types of resources. Identification is important, and we also recommend follow-up care is especially crucial for the preterm and low birth weight babies. I think this is the last slide, and I'll say thank you for listening to me.
Thank you, Dr. Hannah, for that informative presentation. It's really nice to hear what was there before and now what the recommended guidelines. I'm sure there are many questions that our participants have. Unfortunately, I understand that the chat and the Q&A box are giving us some issues. Please do be patient. We're trying to resolve it. So hold your questions and your chat, and the minute it's up, I will let you know. So thank you for your patience on that. With that, let's transition now to one of our main presentations of today, and that is to hear of the experience of Alive and Thrive in Southeast Asia. We'll start with a short video to begin that presentation, then have 2 short presentations and end again with a video. So let's start with the video before I introduce our 2 presenters.
Je m'appelle Plongkyong et je fais partie du groupe ethnique Kotu. Aujourd'hui, mon mari et moi sommes allés faire une visite prénatale pour préparer un dossier d'accouchement. Je vais accoucher dans 6 semaines à l'hôpital du district de Dongyang. Mon mari et moi avons été informés des avantages de l'allaitement et du contact peau à peau dès la naissance. J'ai dit à mon mari que nous n'avions plus besoin de dépenser de l'argent pour acheter du lait en poudre puisque le lait maternel est le meilleur. Mon mari était d'accord. La plupart des personnes vivant dans ces régions montagneuses appartiennent à des groupes ethniques minoritaires. Elles ont une compréhension limitée de la langue vietnamienne. Parfois, elles acceptent ce que nous leur suggérons, parfois elles ne le font pas. Dans le passé, si la mère n'avait pas assez de lait, la coutume voulait qu'elle nourrisse le bébé avec du miel ou du riz lorsque le bébé n'avait qu'1 ou 2 mois. Après que nous leur ayons parlé des avantages uniques de l'allaitement, elles ont compris et ont cessé d'ajouter ces compléments. C'est la 2e fois que j'accouche, mais cette fois-ci c'est différent. Vous allez accoucher dans 15 minutes. Je vais vous aider à mettre le bébé au monde. Détendez-vous, je vais vous frotter doucement le dos. Ma belle-mère est avec moi pour cet accouchement. Elle masse ma tête et mon dos. Elle m'a demandé de rester calme et de ne pas trop crier, ce qui m'épuiserait. Avec elle à mes côtés, je suis plus rassurée que la première fois où j'ai dû accoucher seule. Lorsque j'accouchais à la maison, ma famille et mes voisins étaient à mes côtés pour me soutenir. Donc, comme ma belle-fille va accoucher, je veux être à ses côtés et la soutenir. Les médecins appellent ceci la salle d'accouchement conviviale, ce qui signifie que je peux choisir un membre de ma famille pour m'accompagner lors de l'accouchement. Quand le bébé est né, le médecin l'a posé sur ma poitrine pendant environ 90 minutes. Dans le passé, il séparait le bébé de sa mère après l'accouchement. J'étais inquiète, ne sachant pas si elle pleurait ou avait faim. Cette fois-ci, le bébé est en contact peau à peau avec moi. Et je suis très heureuse. Après la naissance, le bébé est en contact peau à peau avec sa mère pour se réchauffer et établir un lien fort entre les deux. Cette méthode pourrait être inhabituelle pour les habitants de ces régions montagneuses. Mais après avoir reçu des conseils et l'avoir expérimenté eux-mêmes, ils sont très satisfaits et se sentent rassurés de venir ici pour donner naissance à leurs enfants. Après l'accouchement, le médecin m'a dit de me reposer, m'a appris à allaiter mon bébé et m'a encouragé à l'allaiter exclusivement pendant 6 mois. Mon mari comprend également les bienfaits du lait maternel et me soutient dans l'allaitement après la naissance de notre bébé. Je vais allaiter le bébé jusqu'à ce qu'il ait 2 ans. L'hôpital de district de Dongyang dans la province du Quang Nam est l'un des premiers hôpitaux de district du Vietnam à offrir des premiers soins essentiels complets aux nouveau-nés, ainsi que des conseils et un soutien pour l'allaitement. Il a été désigné comme centre d'excellence pour l'allaitement par le ministère de la Santé, le département de la Santé de Quang Nam, Vietnam, le gouvernement irlandais et Alive and Thrive.
Wonderful. Thank you, Alive and Thrive, for that video and for giving us a taste of how things look and feel in Vietnam. It was almost like a virtual tour of the Center of Excellence and some fascinating work there. So let's hear now from Xuong Vu, who is Alive and Thrive's Regional Technical Specialist for Southeast Asia. Xuong leads the strategy development for breastfeeding-friendly health systems in Vietnam and its expansion across Southeast Asia. Under her leadership, hospitals enrolled in the Centers of Excellence for Breastfeeding initiative have tripled over the last 2 years in Vietnam and now reach 1 in every 5 babies. Xuong will be followed by Jennifer Cashin, who is also with Alive and Thrive Southeast Asia. Jen is a public health nutritionist and certified lactation counselor with over a decade of experience in supporting nutrition, food security, public health and development projects in Myanmar and Cambodia. At Alive and Thrive, Jen focuses on strengthening the policy environment and breastfeeding-friendly health systems in Southeast Asia. So Xuong and Jennifer, over to you, and then to end with the nice video that we've seen on the initiative.
Thank you, Nima, for a very nice introduction. Good morning, afternoon, and evening, everyone. I'm Xuong, and on behalf of Alive and Thrive Southeast Asia, I'm very honored to give the presentation following the call from WHO and UNICEF, as Hannah just presented, on our scaling up by adapting the baby-friendly hospital initiative to the local context. As you can see that Dong Giang Hospital that you just watched is one of the 86 hospitals in Vietnam joining the Center of Excellence for Breastfeeding initiative, which is reaching 1 in 5 babies born in Vietnam, and also starts being replicated and sustained by the local government budget and other INGOs like Newborns, Chai Fund, and World Vision. And the implementation at the Dong Giang Hospital, as you just watched, also had to increase the trust in the health system and reduce the rate of womble and newborn mortality rate. Next slide. So after only 1 year, the first year of implementing the initiative, we witnessed the rapid increase in the rate of early initiation of breastfeeding. It nearly doubled and it maintained high despite the COVID-19. As you can see, the picture on the right is a mother confirmed with the COVID-19, but she still has her husband as the birth companion of choice, and the baby in skin-to-skin contact with her immediately after the birth, because she gave birth in the hospital designated as the Center of Excellence for Breastfeeding. Next slide. And we also see the rapid reduction in the number of code violations at the health facilities. At the beginning of the initiative, about 11% of the health staff were reported to advise the formula to the mothers, but after only 1 year, it reduced dramatically to under 1%. Next slide. So how could we get there? Let me give you some context information about Vietnam 5 years ago when we started the initiative. And I believe that you will also find some similarity with the context of the West and Central Africa. So Vietnam is a country in Southeast Asia with a total area of 330,000 square kilometers, about the same area with Ivory Coast and 1/4 of Mali, but with a total population of 97 million people, about 4 times of the Mali. And each year we welcome 1.5 million newborns, and there are 1,200 hospitals in Vietnam with maternity services. And there's a growing number of private hospitals. Now they are accounting for 14%. 96% of the babies are born in hospitals in Vietnam, but only 24% of them receive early initiation of breastfeeding. And the cesarean section is increasing an alarming high of 34%, which is a very big barrier to breastfeeding. And that is why we started this initiative, and we find that the community interventions like mass communication, community counseling can improve the exclusive breastfeeding at 6 months, but it's not enough. We need a model to change the health providers' behavior to ensure the right interventions at the right time, to keep the mothers and the baby together, to enable the breastfeeding. And here are the list of all the providers' behavior that we identified necessary to ensure the successful implementation of the 10 steps. The first one is to ensure the antenatal breastfeeding counseling. Secondly, to ensure the prolonged skin-to-skin contact for at least 90 minutes. Thirdly, to ensure the birth companion of choice. Fourthly, reducing the unnecessary cesarean sections and episiotomy. Fifth, no formula promotion. And lastly, that is, we need to ensure the continuous on-site coaching. That is hands-on and no more theory-based, but hands-on in the delivery world. And as you can see the picture on the right showing the change in the health providers' behavior in Vietnam. The above picture used to be very common in Vietnam when the babies born cesarean will be separated from the mother in the neonatal department when the mother recovers for 6 hours in the operative room. And the below picture, as you can see, is a change after we implemented the Center of Excellence for Breastfeeding initiative. Now even the mothers born to twins, triplet, cesarean sections, or vaginal birth, she will be into skin contact with the babies, and all of them benefit from the early initiation of breastfeeding. Next slide. So what did we do to ensure these interventions happened? We started the initiative by piloting early initiation of early essential newborn care in several provinces with close monitoring of data. And we witnessed that early essential newborn care brought the rapid improvements in early initiation of breastfeeding. And those 2 provinces you can see in the slide, Da Nang and Quảng Nam province, are now turned into the champion hospitals. They play the role of assessment team members for the whole country, although they were not primarily the biggest teaching hospitals within that role. So with this implementation and pilot, we could identify the champion hospitals. They don't need to be the biggest hospitals, but they are the most committed and they're successful. And then their success inspired other hospitals and they turn into the role models. Next slide, please. After the next slide. Next slide, please. And after the pilot, we documented the pilot and integrated into the policy and legal framework to ensure the high-level political will. And that is crucial for the scaling up. So here are the list of 3 most important national guidelines and legal framework that enable the scale up of the Center of Excellence for Breastfeeding. The first one is the Ministry of Health decision approving the Center of Excellence for Breastfeeding mechanism and criteria. Secondly, we included the Center of Excellence for Breastfeeding initiative criteria and designation mechanism into the national hospital standards and accreditation. And lastly, we provide the national guidelines on maternal and early essential newborn care. Next slide. So basically, a hospital will be designated as Center of Excellence for Breastfeeding if they meet the 3 criteria. First, support the mothers to maintain uninterrupted skin-to-skin contact for at least 90 minutes. Second, to facilitate the exclusive breastfeeding during hospital stays, regardless whether they give birth vaginally or cesarean. And lastly, do not promote breast milk substitutes. So you can see that the basic 4 criteria are quite basic, but there are 3 distinctive elements that bring the models to scale that I will explain in the next slide. Next slide. The first, there are 3 essential components for scaling up the Center of Excellence for Breastfeeding. The first is that we expand beyond the central and obstetrics and gynecology hospitals. And secondly, we create the right incentives and motivations for the hospitals and for the health staff when they are designated as Center of Excellence for Breastfeeding, that to generate the demand for Center of Excellence for Breastfeeding. And lastly, that is, we employ the client-centered feedback loop to make to promote the role of the clients and the one who monitor and designate the hospitals as Center of Excellence for Breastfeeding. Let me explain in detail the first element. Expand beyond the central and obgyn hospitals. So we no longer use the central level designation committee. Now the provincial Department of Health can access and designate their hospitals. They are the one who closest to the hospitals because they are in the same province, so they can monitor regularly and closely. And Center of Excellence is not a lifelong title anymore. They will, a hospital after they are designated, they will receive the official reassessment after 5 years, and even after they are designated, they still continue to be monitored by the mothers via phone. And the birth is at the natural process, so we want to ensure that all facilities, not only tertiary, are able to provide optimal maternal and newborn care. And therefore, when we implement the initiative, we always recruit at least 2 hospitals at the same time, including both district and private hospitals. So when we expand to district hospitals, it creates a healthy competition and also have to decrease the overload among the higher level hospitals and also promote equitable care for the marginalized group. Next slide.
Zuang, I'm going to request you to try and wrap up. Thank you.
Yep. So the second element is that we ensure that the client-centered feedback loops. As you can see that after the mother's discharge from the hospital will quarterly send all the numbers of the discharged mothers to the Department of Health, and then Department of Health will survey the mother. And based on the feedback from the mothers, the hospital will be ranked on how well they provide the maternal and newborn care. And that will create the healthy competition and incentive for the hospitals to improve their service. And one hospital told us that they can prepare for the monitoring by the health managers when it is informed to them in advance, but they can't prepare when they are monitored by the mothers every day. Next slide. And lastly, very important is that we tap on the right incentive for the hospitals. That is, when they are designated, we promote them on the media and social media. They are appreciated by the mothers, and the COE designation, as you can see on the photos, is that the hospital will receive a signboard. It will be a signifier of outstanding care for the mothers. So whenever the mothers see that signifier, they will choose where to give birth based on that signifier. And more mothers using the service in the hospital, it means higher income for the facilities. And that is the incentive for the hospitals to maintain the designation and also to generate the demand from neighboring hospitals. And now I will hand it over to my colleague Jen to explain to you more on how we are adapting and expanding this model to the neighboring countries in Southeast Asia. Over to you, Jen.
Thank you, Zung. Next slide, please. Right, so with support from the Government of Ireland, we are working with governments and partners in Laos and Cambodia to replicate the Centers of Excellence for Breastfeeding approach. And as you can see from this map, and as Zung mentioned, the initiative has grown rapidly since its launch in Vietnam in 2019. 86 hospitals in 16 provinces have joined, including 5 provinces that are home to ethnic minority and migrant communities. In Laos, the local term for the Center of Excellence for Breastfeeding is a breastfeeding model hospital. The first 2 breastfeeding model hospitals were designated at the end of 2021, and we expect 3 additional hospitals to meet the criteria by the end of this year. The path to designation in Laos starts with on-site coaching for health workers on early essential newborn care and breastfeeding, then self-monitoring of hospital performance, followed by an external validation assessment that includes interviews with postpartum mothers. Laos is also in the process of developing a mother's experience survey that is similar to the one in Vietnam, but has some changes to match the local context. The Centers of Excellence for Breastfeeding in Cambodia builds upon a strong foundation for early essential newborn care, as well as updated national guidelines on BFHI, which reflect global recommendations. Cambodia has scaled up early essential newborn care to 25 provincial hospitals, 2 district hospitals, and 2 national hospitals. At each hospital, multidisciplinary core teams are there to monitor EENC performance and report data to a national database. Therefore, our approach is to incorporate indicators that measure the 10 steps to successful breastfeeding into those monitoring checklists that the hospitals are already using. And that was achieved this year when the Ministry of Health approved new EENC quality improvement guidelines. Now we're working with the Ministry of Health, WHO, and partners to shortlist potential COEs, Centers of Excellence, based on their performance on newborn care and on their previous designation as a baby-friendly hospital. Then they will receive an external assessment and be designated as Centers of Excellence by the middle of next year. Next slide, please. The updated guidelines on the BFHI call for countries to integrate the 10 steps to successful breastfeeding into their national healthcare systems to improve access and coverage, and encourages countries to develop their own approaches to operationalizing this recommendation. The Centers of Excellence for Breastfeeding approach embeds the 10 steps into national quality standards and accreditation systems to achieve coverage and scale. In Vietnam, the Centers of Excellence standards are embedded in the National Hospital Quality Standards, which means that every hospital nationwide is assessed for performance. The initiative also provides tools and assessments to support implementation and sustained provider behavior change. Major components of this are the on-site coaching that Zung talked about, as well as the Mother's Experience Survey. In Cambodia, Centers of Excellence indicators like early initiation of breastfeeding and exclusive breastfeeding during hospital stay were integrated into the monitoring checklist for early essential newborn care and are self-reported by the 29 hospitals monthly. In Laos, the Breastfeeding Model Hospital Initiative indicators are embedded in the National Hospital Quality Assurance System and Newborn Care Quality Standard, and they build upon a strong government commitment to early essential newborn care, and bring the additional component of an external assessment and soon a Mother's Experience Survey. In all 3 countries, the initiative builds upon monitoring systems that are already in place and functional, such as the Hospital Care Quality Standards and the DHIS2 in Cambodia. Next slide, please. The Centers of Excellence approach was recently featured in a case study by the Global Breastfeeding Collective, which describes in detail how the initiative builds on existing systems and provides the tools and resources to facilitate implementation and maintenance of quality standards. Next slide. So I would encourage you to check out the Alive and Thrive website. We have a dedicated page to this approach, the Centers of Excellence for Breastfeeding, and a number of resources that are available in English and a few in French as well. So, and I also encourage you to reach out to members of our team if you're interested in learning more. And now I'll close, next slide, with a short video summarizing the Centers of Excellence for Breastfeeding approach. Thank you so much for your time and attention. Over to the video.
L'allaitement est naturel, mais pas toujours facile. Au Vietnam, 94% des naissances ont lieu à l'hôpital, mais seuls 27% des nouveau-nés sont allaités dans l'heure.
7% are breastfed in an hour after their birth. And many babies did not get really the colostrum that is only produced 72 hours after birth. The Centers of Excellence for Breastfeeding support early initiation and exclusive breastfeeding before being delivered from hospital. They work hand in hand, with mothers to provide mothers an optimal source of nutrition immediately after birth. The Center of Excellence practice correctly the first essential care to newborns. They provide skin-to-skin contact during 90 minutes without interruption and make sure that babies remain in the room with their mothers in the room hospital. This contact, skin-to-skin contact during 90 minutes is really ideal for the newborn to really implement the first 9 instinctive behaviors to locate the breath and be breastfed for first time. The healthcare providers do provide instruction for timing, for how to breastfeed in initial stages. Mothers do get these instructions immediately after delivery and during control visit after delivery, so that they can really practice exclusive breastfeeding during the first 6 months of the life of the child, and sense that they're capable for really generating this all the way up to the 4th or 5th month. At Centers of Excellence for Breastfeeding, we not want to really promote the bottles and teats, etc. And the designation of Center of Excellence is granted by the Ministry of Health and or provincial district in charge of health. This is based on responses provided by mother during a phone interview that is completed, and on the assessment that is conducted by the Ministry in charge of health and by provincial Department of Health in partnership with Alive and Thrive. After having been designated the Center of Excellence for Breastfeeding, will conduct their own annual evaluation, and ministries and provincial districts will organize quarterly surveys targeting mothers, and will have an external survey every 5 years. You may, when you get to the Center of Excellence, your child will have a kickstart, really a good kickstart, and ready to hit the road. Thank you. Hospital, is it a Center of Excellence for Breastfeeding? Well, who knows?
Wonderful. Thank you to the Alive and Thrive team. There's lots of comments in the chat box for the energy and the enthusiasm, and I hope you will continue with it. We have 2 key questions in the chat box, and I would request Dr. Hannah and the Alive and Thrive team to answer them in writing in the Q&A box so that we can move on. The first question is on step 9. A lot of participants are seeking clarification on what it means that, if health workers are able to medically prescribe it versus, I guess, mothers opting to use pacifiers and teats. How would you distinguish between the two? And for the Alive and Thrive team, there's a question on incentives given to health facilities and what these incentives are. So if those could be answered, that'd be fantastic. With that, let's move on to our next session, which is a panel discussion with 2 absolutely wonderful speakers from Côte d'Ivoire and Mali. And I'd like to introduce our first panelist, Dr. Renee Oka. Dr. Renee Oka is the Director Coordinator of the National Nutrition Program at the Ministry of Health, Public Hygiene and Universal Coverage of the Ivory Coast since 2017. He is a medical doctor by training with 18 years of experience in public health, including working in humanitarian action nationally and internationally. Welcome, Dr. Oka. We also have with us from Mali, Dr. Aissata, who is the Chief of Section for Malnutrition Management and the Fight Against Micronutrient Deficiencies. She has over 4 years of experience in public health and has been coordinating this initiative since 2019. And the process of revival and implementation of the new recommendations of BFHI. So bienvenue, Dr. Aissata from Mali. I will pose my questions in English, but our panelists have requested that they respond in French. So for those of you who are listening in English, I would request you to switch on your translation button soon. So with that, Didenu, can I have the first question up, please? So Dr. Oka, I'm going to start with you first. Can you help us as the audience get a feel of what the situation in Mali is like? How many babies are born every year? What is the rate of early and exclusive breastfeeding? How many institutional deliveries happen? And more importantly, how many facilities in Mali provide maternity services? And then once we hear from Dr. Oka, Dr. Aissata, I will ask you to respond to the same question so we can get a feel of what's happening in Mali and Côte d'Ivoire. Dr. Oka, over to you. Dr. Oka, if you're able to unmute yourself. Fantastic. Over to you.
Merci. Voilà.
Thank you very much. I would like to thank the organizers for organizing this webinar. Côte d'Ivoire is happy to participate in this session. Regarding the situation, breastfeeding situation in Côte d'Ivoire, we have statistics. Breastfeeding, exclusive breastfeeding evolved from 2012 to 2016 with raised at 12%. Now we are at 23.5% with our goals for 2020 is 50%. These indicators have improved over that period, but unfortunately, we have a lot to do overall, and we observed that the proportion of infants increased from 30% to 36%, which is quite low. It is low for infants whose mothers delivered with high qualified health personnel. These deliveries is estimated at 73%, which reflects the low support to maternal breastfeeding in our health system. In the 2021 survey, we'll have the figures very soon. Regarding deliveries in our health system, in 2020, we had about 718,000. 2021 is 639,000, and the delivery rate in institutions is in 2020 is 91%, and in 2021 at 90%. You have to know that on the more than 30,000 health facilities, roughly 2,000 offer maternal services. So that's the situation in Côte d'Ivoire. Thanks.
Thank you, Dr. Oka. So that's quite a staggering number, and I'm not sure if I heard right, but over 90% of deliveries in Mali happen in health facilities. Is that correct? Wait.
Yes, that's what I said.
Okay, perfect. Great, thank you. So with that, Dr. Aissata, over to you to hear, let's hear from you about how many babies are born every year and what is the rate of early initiation and institutional delivery. So let's hear from you.
Thank you. It's a real pleasure for Mali to participate in this webinar regarding the situation in Mali in terms of breastfeeding and regarding babies. We, from December to January, 349,000 births. And regarding initiation of breastfeeding, we are at 83.5% based on the survey in 2021. Exclusive breastfeeding, for that, the rate is 47.8% in the SMART survey 2021. Regarding the proportion of births in health facility, we are at 44%. And regarding maternity, we are at 1,500, like public urban. So regarding the rate of exclusive breastfeeding, we've seen an improve compared to 2020. We have the preliminary results of the SMART survey, which has yet to be published. And we have seen an increase at that level. Thank you. Over to you.
Fantastic, Dr. Aissata. So the statistic that's got my ears ringing from Mali is that almost 84% of babies are breastfed within the first hour of birth. And that is quite commendable. And we would really look forward to hearing more from you as we go through this panel. So with that, let's go to the second question. And I will pose that first to Dr. Aissata and then to Dr. Oka. So Dr. Aissata, with this amazing rate of early initiation of breastfeeding, since when has Mali been implementing the BFHI guidelines? And what would you say are one or two key lessons that you have learned from your experience of implementing BFHI in Mali? Over to you, Dr. Aissata. Dr. Aissata, you're muted. Sorry.
Oh, I'm sorry. I'm sorry. I was saying that since 2002, Mali is involved in the labeling process of its entities from 2000 to 2009, 8 years. We have 50 labeled structures, 3 hospitals and other health reference centers, and 23 community centers, and 2 private structures. With the new guidelines of 2018, we revamped the initiative from 2019-2022, that is 4 years, by making assessment of already labeled structures, and also have the operationalization of new recommendations. So we have 8 years of implementation before the new guidelines and 4 years for the new recommendations. Now, regarding the implementation and the lessons learned, as the first lesson, it's about reinforcing collaboration with the communities to support breastfeeding, using support groups, targeted people that can help the BFHI approach. So the participation of the communities has helped a lot with the good results that we have in the implementation of BFHI. So as a second lesson, we realized that to make it sustainable, we need to implement monitoring programs and quality assurance programs, and this we lacked that kind of mechanism during the implementation. Thank you.
Thank you, Dr. Aissata. So I heard 2 important things. You have a very strong community component to the program, and you have introduced some quality assurance, or you feel quality assurance and monitoring is key for sustainability. So let's hear from Dr. Oka, and then could you go to the next slide, please, which is the question, which is the second question. So Dr. Oka, we can refresh his memory. Dr. Oka, since when has Côte d'Ivoire been implementing the BFHI guidelines, and what are 1 or 2 key lessons you feel you've learned in Mali with such a high rate of institutional deliveries? In Côte d'Ivoire, my apologies. Over to you, Dr. Oka.
Thank you. In Cote d'Ivoire, we started the BFI approach in 1993. We recorded 115 hospitals that are labeled with support group. We have about 100 support groups, but we've seen a slight decrease in 2022. And this is related to the lack of follow-up mechanism. In 2012, we started to revamp the initiative with 2 hospitals, labeled hospitals, and and following that revitalization, we accelerated the process in 2018, where we drafted a scale-up plan with the new recommendations. And these included 2 major changes. The first one is the training. Staff training is done on site in the health facility itself. And the second change is the decentralization of the approach, which will allow the teams to continue different steps: training, supervision, internal assessments, in order to cover very quickly the whole country. And to that regard, we have drafted the standards and procedures to implement the BFHI. And from 2018, we labeled 34 health facilities. And since 2022, we started the process to include 65 BFHI hospitals. As lessons learned from this approach, for us, it would be key to integrate the commitment of providers at the onset of the process, and monitor the effects of our different actions. We also have the need to have a follow-up mechanism from the health district to the national level. And then we have also to know the gains of this approach. And we were able to highlight the success that we can get from the co-creation workshops, where we invite all stakeholders, and also how we can implement and have training support. So these are the main lessons that we were able to draw from the implementation of the approach. Thanks.
Fantastic, Dr. Oka. It's humbling to learn that Cote d'Ivoire has had 30 years of experience in implementing BFHI, and I think that is evident in the numbers that you cited with respect to institutional deliveries and the breastfeeding rates. It is, I think, a lesson for all of us in the region to look at more carefully. I think one key takeaway that I heard from you is how you've shifted your training for health workers to be on site and in the facility, as opposed to classroom training, which many of us are used to doing in our country. And again, I think it's a lesson for us to all look at, and also how quickly you have managed to scale just even in 2022, 65 BFHI facilities. So that is fascinating. Thank you. But the last question now to both of you, Dr. Aissata and Dr. Oka, and I'll request Dr. Oka to go first. Now that you have heard from Dr. Hannah about the updated and revised BFHI guidelines, and you've heard from Zung and Jennifer the innovative experience of centers of excellence from Southeast Asia, what are the 1 or 2 things that you think you would now, moving forward in each of your countries, do differently? What is the 1 or 2 key takeaways and a challenge that you foresee? So Dr. Oka, over to you. Dr. Oka, you are muted.
regarding the Southeast Asia experience, I have noted a lot of things. I can note the assistance provided to the husband, to the mother, to the husband. I integrate the whole process, and regarding breastfeeding, I have also noted the incentives in the labeling process. I think it's something that we can look at, and also that client-centered monitoring. I think it's a good thing. We have to see how we can capitalize on that. You know, also that honest competition among hospitals, and also the promotion through the media and through social media, how to make it valuable, how the learning side, how the centers of excellence can be valued at the community level, and how we can promote the gains of such an approach. I think these are some of the things that we can use in our own context. For us, this is very, very important, and we will see how we can use in our own context. And regarding the challenges now, Cote d'Ivoire is committed for the next years until 2025 to increase breastfeeding rates to 72%, right? It's a major challenge, and this requires a favorable environment and many other changes in terms of performance follow-up. What I would like to share with you also is that after the adoption of our presidential decree regarding breastfeeding, we signed a lot of ministerial orders regarding the use of milk formulas, and the other orders regarding the reduction of advertisement regarding the milk formulas. And I think this is supported by the private sector, which will help us have a good environment regarding the promotion of breastfeeding. There are ongoing discussions regarding the compliance with these ministerial orders. It includes the Ministry of Health, the Ministry of the Industry, the Ministry of the Family, the Child, the Ministry of Communication. So this multi-sectoral approach will contribute to the success of this implementation to reach our target. This current approach will be based on information and sensitization of populations and implementation of the other approaches. Apart from the directives regarding ENC, the community engagement and the issue of applying the law regarding breastfeeding is still challenging, because people just still need to respect that order. I think also we have to think about the effective use of available resources, and this sometimes can be a challenge. So these are the perspectives and challenges that we are thinking about and looking for solutions. Thank you.
Thank you, Dr. Oka. Lots of key takeaways for you and big challenges as we strive to improve breastfeeding rates. Dr. Aissata, let's hear from you about Mali. Now that you've heard, I mean, Mali has done an impressive job too in applying the BFHI guidelines to date, but now that you've heard of the updated guidelines and the experience from Southeast Asia, what are the one or two things you think you would focus on or do differently? And what is the one key challenge you foresee? Over to you, Dr. Aissata.
Thank you. I thank you for this experience sharing regarding the new guidelines. As Dr. Oka has said, we have learned a lot, and we plan to use this to improve our processes.
In this regard, we've noted the involvement of champions in the process in order to ensure the success of the practice and performance contracts. In addition to that, we would like to carry on the integration of the 10 conditions, the 10 steps for the success of this program in all the national documents, in all national policy documents. We have opted, we don't want to use certification processes, but rather we want to, these 10 steps should be involved in the maximum packages in all structures. Other way forward, so we'll do an advocacy action targeting BFHI for better use of non-commercial products. We'll be targeting policy makers, technical financial partners, district level leaders at the national level, at the community level, at the subnational level, at the district level. Now, concerning BFHI, will try to have a national coverage. We'll try to really target all centers. All centers will be turned into baby-friendly hospital initiatives. Now, concerning the code, we have a process of reviewing our code. So our decree dates back 2006. So we'd like to really do advocacy action, advocacy work, so that we can really adopt this code, so we can implement it fully, and so that we can really put in place monitoring mechanism. So the challenge ahead of us is the implementation of monitoring, internal monitoring mechanism for the sustainability of this initiative. Also the mobilization of resources, domestic resources, external resources for the implementation of these recommendations. Over.
Thank you. Merci, Dr. Aissata and Dr. Oka for being with us. Lots of exciting information from both of you, including lessons and key takeaways that you have. Just to summarize, I think, Dr. Oka, you mentioned that involving the companion in the delivery room is something that you're going to take away. And this is a lesson that we've seen globally in many places. We focus sometimes only on the mother or the child or the mother-child dyad, but it is important to look at what we call the triad, the mother, the baby, and a companion, be it her mother-in-law, her mother, sister, her husband, in the delivery room to make the experience much more personal and client-centered. I think you also spoke about the promotion in social media and how you can leverage new technology to talk about this. And Dr. Aissata, a big challenge that you mentioned, or future for Mali, is to look at national coverage. And I think we've seen this, unless all facilities upscale themselves to a certain standard, particularly all the teaching hospitals, we will keep trying to reinvent the wheel and keep needing to train and retrain our health facility workers. We need to make sure that early initiation within an hour and exclusivity of breastfeeding, whether for preterm, low birth weight, and normal babies, is the norm. It is the new normal and the narrative for breastfeeding. So with that, I'm going to try and transition now to our closing remarks. But before I do that, a few housekeeping things. Lots of questions have been posted. Our organizers, Alive and Thrive, UNICEF, and WHO, will make sure that those questions are all answered, and will distribute that to those of you who've been online with us today. So if your question hasn't been answered today, don't worry, it will be answered. Some of you have asked for the presentations. I believe those will also be available and sent out, and I believe would be maybe Manisha or Did, and you can confirm, would those be available online for participants to go to on the Alive and Thrive website? And then I think any resource materials, as Jennifer shared, are available on the Alive and Thrive website. I know there's a question from Marina which says, how can UNICEF offices help with translation of the new BFHI materials in local languages? I believe these are already available in several key languages, but we can check and see if your country doesn't have it. I'm sure the UNICEF office there would be happy to support it. So with that, I'd like to thank our panelists again, Dr. Oka, Dr. Aissata, merci beaucoup for being with us this afternoon and sharing very, very relevant and practical experience from your countries. And I will now call upon Dr. Hannah back again to give us some closing remarks and next steps for the region. So Dr. Hannah, over to you.
Ladies and gentlemen, we are at the end of this webinar, as mentioned. On the behalf of all the partners, WHO would like to express our gratitude for your precious time discussing how to accelerate the implementation of the 10 steps successful breastfeeding in Western Central Africa. Within the past hours, we have listened to many ideas and experiences, all geared towards improving child health through promoting, supporting, and protecting breastfeeding in facilities, providing maternity and newborn services using baby-friendly hospital initiative approach. Building the capacity of stakeholders through education and transformation of existing systems, including mechanisms to monitor and improve the performance of health facilities, will ensure breastfeeding friendly health facilities and communities. Therefore, innovative approach such as, like you mentioned in your area, a center of excellence, it basically this is quite an interesting phenomenon, but we should also bring into consideration there are other ways of scaling up those initiatives based on the country context. But the model shared by Southeast African countries are critical, and they have been used to overcoming some of the challenges. So there are some lessons that West Africa can get from that experience. What stands out from our discussion is focusing on health providers' behavior and health facilities, carrying out right provider-driven intervention at the right time, integration of the FHI guideline into the national protocols. There are positive steps which will go a long way to facilitate the implementation of the 10 steps to successful breastfeeding. I'm pleased to see that this meeting was also an opportunity for strengthening relationship and collaboration between UN agencies, technical and financial partners, government institutions, etc. This collaboration is essential for the successful development and implementation of PFHI, and I urge you to maintain and strengthen it continuously in your respective countries. I'm very grateful for Alive and Tribe and UNICEF and all our partners for their tireless commitment to pushing the breastfeeding agenda forward. I would like to reaffirm that WHO will continue collaborating with you all of you to ensure every baby starts right life by scaling up and providing universal quality of care in a baby-friendly environment. Let me conclude by retiring, oh my God, reiterating my congratulations to all of you for your active participation, your valuable contribution, ideas, and shared experiences, which permitted us to achieve the objectives of the webinar. I hope we will all continue to foster partnership and collaboration to improve breastfeeding outcomes globally and specifically in the Afro region. I would like to thank all the colleagues who contributed to the webinar organization, and including interpreters. Thank you for your dedication, and thank you for your attention. Have a good day.
Thank you, Dr. Hannah, for those closing remarks. And with that, we come to the end of our webinar today. Thank you to everybody for dialing in. We had a wonderful audience of over 100 participants with us today. There have been lots of questions, particularly on step 9, and I would request the Alive and Thrive WHO and UNICEF teams to make sure as we send out materials post-webinar that we answer the nuance of where bottles and teats are permissible or supported in the BFHI initiative versus when they're not, and how it relates to the code. I think that clarification would be useful for us as program implementers in countries to have. And we would love to also hear much more about Mali and Cote d'Ivoire and how we can apply lessons in our region from there. I think one challenge for a few of the other countries in the region here is we don't have such high rates of institutional deliveries. Particularly, I can speak about Nigeria, and I know the context in Niger and a few other countries. How do we make sure, I think Chinwe mentioned it, we have what we call baby-friendly hospitals and baby-friendly communities. So how do we encourage, even where home deliveries at home and births at home are quite prevalent still, how do we make sure that both communities and health facilities are baby and breastfeeding friendly? So thank you for that. And with that, over to everybody to turn on your videos, say bye-bye, say hello. And it's been wonderful being with you this afternoon. So good morning, good afternoon, good evening to all our participants, and a big thank you to all our speakers and presenters today. Merci, obrigada, and thank you.
Thank you. Bye-bye.
Merci.
Thank you. Bye.
Bye.
Thank you, everyone. Bye-bye.
Thanks, everyone. Take care.
Thank you, Didinu, especially to you for all the tech support, and to Yassine